Thank you to all our participants for joining today's conversation. A particular thank you to our Dean's Office and our communications teams, without whose efforts these conversations would not take place. And thank you to today's co-host, the Boston University College of Communication. Today, we're going to discuss public health communication in a changing world. New technologies, fast-paced media environment, and the rise of misinformation pose challenges for our ability to communicate effectively with the public. Disseminating accurate information, earning and keeping the public's trust, and creating a big tent movement to promote better health for all means reflecting always on how we can communicate better. I look forward to doing so today. I am delighted to introduce our moderator, my good friend and colleague, Dr. Mariette de Cristina, Dean of Boston University's College of Communication and Professor of the Practice in Journalism. Before arriving at Boston University in 2019, Dean de Cristina was the first female editor-in-chief and executive vice president of Scientific American, as well as executive vice president of the magazine's division of its publisher, Springer Nature. In that capacity, she also oversaw the journalists for the journals Nature magazine, as well as Nature Research, Custom Content, and Publishing Groups. Professor de Cristina is also a fellow of the American Association for the Advancement of Science and serves on a range of advisory groups and has done so for many years. It's a real privilege and an honor to work with Dean de Cristina, and I will now turn it over to her. Mariette, thank you.
Thank you so much, Dean Galea, for that really kind introduction. It's my genuine pleasure to be moderating today's discussion. I'm especially pleased that we've incorporated the dimension of trust in our theme today. As the saying goes, communication moves at the speed of trust. I'm really looking forward to learning more about that and other things from our esteemed panelists. I'd now like to introduce our speakers for this program. First, we are going to hear from Joan Donovan, an assistant professor of journalism and emerging media studies at Boston University's College of Communication. Dr. Donovan is a sociologist of knowledge who examines internet and technology systems, online extremism, media manipulation, and disinformation campaigns. Prior to joining Boston University, Dr. Donovan was the research director at the Shorenstein Center on Media Politics and Public Policy, where she led a world-class lab addressing media manipulation and disinformation's impact on public health, national security, and global politics. Next, we will turn to Stephanie Friedoff, co-founder and co-director of the Information Futures Lab, professor of the practice, and senior director of strategy and innovation at the Brown University School of Public Health. She is a leading media, communications, and global health strategist and an expert at knowledge translation, information creation, and verification. From July 2022 to May 2023, Professor Friedoff served as Senior Policy Advisor on the White House COVID-19 response team, focusing on population information needs, health equity, communication engagement, and medical countermeasures uptake. Then we will hear from Matthew Krueter, the Kahn Family Professor of Public Health at the Brown School of Washington University in St. Louis. As founder and senior scientist of the Health Communication Research Laboratory, Dr. Krueter and his team partner with the national and community organizations to develop and evaluate a wide range of health communications programs to address health disparities and improve the lives and health of low-income Americans. Finally, we will hear from Kaditya Ndaye, Associate Teaching Professor in the Department of Prevention and Community Health at George Washington University Milken Institute School of Public Health. Dr. Ndaye also serves as the director of the Public Health Communication and Marketing Program. Her research centers on culture, global health, and behavior change communication. I'm really excited to learn from each of you. Thank you so much. Dr. Donovan, over to you.
Thank you, Dean Christina. I really appreciate it. And hello, everybody. I see there's 358 people on the call, which is pretty miraculous. I hope that you're sitting down somewhere, drinking a coffee and enjoying yourself. As Dean Christina said, that I'm a sociologist by training, but I also care very deeply about information integrity, particularly questions that are life or death. And what we've noticed over the years is there's been a major shift in how people search for health information, the kind of health information that they're willing to share, and then the kinds of medical misinformation or conspiracy theories that bring them into what we might call rabbit holes or echo chambers, that are driven by the way in which technology is designed. So when I study a problem like medical misinformation, I'm looking at ABCD: actors, behavior, content, and design. And we can't leave out the design of our communication systems, because culture, politics, public health is all downstream of infrastructure. So we've had a major change, and we're starting to see it reflected in Gen Z, of people who have a wealth of knowledge at their fingertips. And yet, even if they are given the facts, they are choosing to either not get vaccinated, or they're choosing other health alternatives that are really framed as alternatives here. And they're trusting different people. Part of it has to do with the medical system itself in the US. It is hard to get a doctor. It's hard to activate health insurance. There are all these premiums and prices. So even when people were trying to get the vaccine, they were being inundated with hoaxes and scams saying, you know, the vaccine costs money, or pay $20 to get in line for the vaccine. So what we noticed was that media manipulators and disinformers weren't hacking anything, but they were utilizing social media infrastructure to spread lies, some of them financially profitable, other times profitable in terms of the clout or the network power that they would use. We also shouldn't be that surprised that in the middle of a pandemic, it becomes a politically expedient to pretend as if the cure is already here, for instance, hydroxychloroquine, or that in the case of ivermectin, it's a cure, but it's not usually used in humans. And so what's important to understand here is that when people are sharing health misinformation, they're by and large sharing because they care about people around them. They think, well, we don't have enough information. And of course, there was an immense data void in the pandemic about where coronavirus came from, what it was doing to human bodies. These, you know, talk about trust and communication moving at slow speeds. It throws science in there, and it really slows down. But that doesn't stop media manipulators and disinformers from essentially taking up all the oxygen online and pushing very corrosive and damaging ideas, and oftentimes twisting news stories. Like when Hank Aaron passed away, there was a big blow up about an RFK tweet about Hank Aaron dying of the vaccine. And at the time, Twitter chose not to take that tweet down, and it's still up. But even the family of Hank Aaron couldn't correct the record. And we've seen this in the past with things that are not health related, like Obama's country of birth. So what is essentially being sold here, and this is my last point, is that when people are going online and in an information seeking mode, we need to have much better communication around what we know, what we don't know, and what the public health implications are. I have started to think about and starting to work through a campaign where we would start to use .med or .health in the same way that we use .gov and .edu. I think, you know, when we have trusted domains, they tend to perform pretty well. People know that it's a university when they're on .edu. They know it's a government or a town website when they're on .gov. How do we make sure that they know they're getting public health information, or they know that they're at a clinic's website, by shoring up some of the more important institutions online? And, you know, one of the things that drives a lot of this medical misinformation isn't just that people are sharing because they care about each other, but also that there is a deep mistrust of media, of politicians, and that deep mistrust has been earned over the years. And so what's at odds here is the way in which they are trusting certain influencers or people that are consistently giving them forbidden knowledge. That is conspiracists that say, come back tomorrow because we have a bombshell about the Biden White House, or we have a bombshell about the CDC. That's a rhetorical strategy, and we've seen it used over and over and over again. And I will answer those questions in the chat as we move on here. Thank you.
Thank you so much, Dr. Donovan. It was really interesting to learn more about how technology platforms are shaping our public health conversations and our ecosystem, that these platforms can be hijacked by bad actors or even politicians with particular points to be made, and that there is deep mistrust in the populace for reasons over many years of time. And going forward, when the public is in an information-seeking mode, we need much better communication approaches, including the very intriguing idea of the .med to project trustworthy platforms. So having said that, thank you again. I'd like to turn it over next to Professor Friedoff.
Well, thank you so much, Joan, for getting us started in such a terrific way. And to Dean Galea and Dee Christina for having us today for this important conversation. So much already what you mentioned, Joan, obviously resonates. And I feel a little bit like you've laid the perfect groundwork. I'm going to try to summarize and drill deeper on some of the things that you've shared. And I'm a journalist by training, so I'm going to make it 4 key misconceptions that people have about all of this, and what we need to do to overcome them and make progress on better connecting people with the information and the health information that they need, both to live healthy lives and participate in society. So number 1 is people think we live in a misinformation crisis, but as Joan has just shared, we don't. We live in an information crisis. So to build a little bit on what was already shared, technology is rapidly changing how we consume information, and where we consume information is rapidly changing. AI is just the latest piece of this, and there are very few guardrails as we're trying to navigate this moment. That also means this exponential growth, and we're seeing this again with AI right now, that our information spaces are exploding with information. Way fewer gatekeepers. In the pandemic, we had all this experimentation with labeling and taking posts off. All of those have gone away at this point. And because none of us is this guy here, that means that people are increasingly more confused, have more information needs, and are more vulnerable to misinformation and negative health outcomes, as Joan has also shared. So that is why we really need to, yes, focus on understanding misinformation. And again, I want to point out that Joan is one of the leading researchers on this, because she does such deep case-based work. It does not help us to know all the misinformation is out there if we don't understand how it resonates with people and why. And that is why we want to understand people's concerns, questions, and confusion more broadly. And that is actually the part of the information ecosystem where we can make a lot of change and have a lot of impact. So I wanted to share a little bit about one pilot we just did in South Florida with Spanish-speaking diaspora communities. We worked with 25 community leaders, and in just 6 weeks, over 500 questions from the community were brought forward that they wanted answers to. What are these types of questions? How do I get a mammogram in South Florida if I'm uninsured? How much can a landlord raise the rent in Florida? We all know there's a housing crisis going on in the country, and it's playing out in communities. And people have these information needs. Is it true there's no plastic in the cloud? So news and different snippets that people hear everywhere, they have questions about that. Do I really need another COVID vaccine? Lots of COVID vaccine questions, obviously, always. And then a key question that came up every week actually, is the 2024 election still happening? Alexa says the 2024 election is not happening. So this is where we can see where and how misinformation is particularly impacting communities. And I'm sure Dr. Kreuter will talk more about that because he's doing exceptional work on this more broadly. So number 2, quality information is freely accessible to all. It is not. And it's a key part of what we need to understand about where and how our information ecosystems are broken. We are an extremely diverse country and community, and at the same time, our information ecosystem is not made for that diversity. There's so many barriers. So in our work with communities, and next to Florida, we've worked in many cities in the United States, we find that information often lacks appropriate language and cultural cues, is designed solely for high-speed internet access. It's behind a paywall, it's not in the right language, it's not in the places where people actually spend their time to get information, it's not designed for people with varying levels of literacy. So if you come from a country that, doesn't have health insurance, or which the healthcare system works very differently from the one we have here, you have a lot of questions, and the information that's out there is not necessarily helping you with that. And then, of course, the information too often is delivered by messengers that people don't trust, or only a little, as Joan has also shared. So especially for this community here, information is a social determinant of health, and we need to acknowledge and treat it as such. And we need to understand that information inequities are real. Number 3, if only people had all the facts, things will be different. Probably not. Why? Because relationships trump facts every time. And what's so interesting about this is that we continue to perpetuate outdated communications models, and we continue to ignore the actual behavioral sciences on how people engage with information. So too much of public health communication, especially from authorities, is top-down and linear, is based on traditional ideas about expertise and something that we call the deficit model, which means I'm the expert, I have all the answers, I'm ready to deliver them all to you so you can listen and take it in. There are no feedback loops, and more facts are the answer. And we've seen this play out over and over again in the pandemic, with people just screaming at each other, right? Who had the better facts? Of course, the ecosystem that we live in is dynamic, it's organized, it's participatory. Expertise comes from experience, it comes from many different places, and it should, I would argue. People feel they're heard and they have agency, and there's that recognition that humans have an emotional relationship with information. That is a core thing that we as experts and as journalists need to understand. So I was so excited about this seminar, in part because I'm a journalist by training. I do work in public health. It brings all these communities together. So I had to make this slide for journalists, because everything I just shared is also true for too much of our journalism. We have a news voice, the facts come first. Engagement means getting people to consume our content. And we're not in the spaces where people discuss and try to make sense of the news. We drop the story, we maybe engage on social media, and then when people start discussing it, we're mostly gone. And again, this happens in an environment that's built for storytelling, where relationships come first, where engagement is shared through experiences and identities, and people feel they're heard and understood. Here's just one quick example of that. When Nicki Minaj heard during the pandemic that she had to get vaccinated to go to the Met Gala, she posted on Twitter about, I'm thinking about this, vaccines, don't know yet. And Kevin M. Kruse, who is a fantastic historian at Princeton, and I'm not calling him out here, this is just one example of something we've seen so much, but terrific expert, right? All the good things, he's part of the 1619 book, everything is, But what is he posting here? Do your own research? Do you have a team of scientists running clinical trials out of your spare bedroom? That's condescending. That's not how you have a conversation. That's not how you engage anybody in wanting to learn more or feeling confident about engaging with science. Now, of course, the amazing Kizzy, who is one of the co-inventors of the science behind the Moderna vaccine, posts, I emphasize with the sentiment, I want every single person to get vaccinated out of their own informed will. And I'm here if you want to chat, or I could be your med date. So empathy and humor, this is how we need to engage. And last one, we need better dissemination strategies to get the right public health messages to people. I would love for us to all strike the word dissemination from our vocabulary. We need to engage. These are not one-way streets. We don't need better dissemination strategies. We need to build infrastructures of trust. So what do I mean by that? Too often in public health, we show up when we want something. During the pandemic, all of a sudden, we wanted people to get vaccinated. And we started moving into communities who have a lot of other issues, who have, all kinds of health concerns that for them were much more prominent than the risk that came from COVID. What we do to build infrastructures of trust, has to start with listening. And when we do that, we also need to equip and empower the trusted messengers that are already in our communities. We need to build new communications infrastructures at the local level. We worked in 5 cities in the United States with low-wage communities of color for over a year. And while the vaccinations across the country were going down, through this ground level engaged work, vaccinations in those communities kept going up. And that is because we didn't start with the vaccine. We embedded the vaccine. We asked people, how does the vaccine fit into your life? Those are the questions that we need to ask as we think about the public health goals, again, that come from authorities and other people versus the health goals that the communities have that we should be focusing on. So we need to be where the people are. These are just 2 examples from our pilot in Florida, where we experimented with being on WhatsApp with very short messages that could help answer these questions that the community had shared with us. And of course, I can't help but showing how the Washington Post is currently trying to do some of this engagement better on TikTok. Love that we're a newspaper still at the bottom. So, change is underway. We need to stop leaving the sense making to the bad actors. This is really important. And, for the sake of time, I won't talk too much about this example, but there's still, for example, this outdated thinking that you can drop a difficult news story on a Friday. It actually has the opposite effect, because what do people do on a Friday afternoon? They have time to be on social media. They have time to have discussion. This was a difficult moment for the CDC to communicate about a potential risk for the COVID bivalent vaccines. And, they posted it on Friday too through access journalism, which also needs to stop. And by 5 p.m., the Twitter spaces were full of discussions about it. So by following these 12 steps, we lay them out. I shared the link here under buildingvaccinedemand.org. These don't apply just to vaccines, they apply broadly. But we have a playbook for what we need to do, and it needs to focus on building these new local information infrastructures, using storytelling and accepting that people have a relationship with information that's emotional, and building strong relationships regardless of the individual issue that we're trying to talk about at any specific point in time. That's how I think we can build a better future for both our information spaces and for public health communications. Thank you.
Thank you so much, Dr. Friedhoff, for those fantastic insights. So we heard more about how information technology is advancing rapidly, how we need more focus on people's genuine concerns, which was a fantastic theme, and that there are so many public information barriers. Dr. Friedhoff also talked about the old model of information deficit now that doesn't work, and mechanisms by which we can build infrastructures of trust. And I'm really looking forward to discussing those a bit more. Now let's turn to Dr. Kruder. Thanks very much.
Well, I think Stephanie and Joan, thank you very much for really teeing up what I'm going to talk about here. We've tried very hard to apply much of the sort of wisdom and insights that you've shared already. I'm going to talk about what we believe was the first local system in the US to monitor and respond to inaccurate health information. and just as importantly, to promote accurate health information in communities. And this is a system that has been up for almost 3 years now, and it's called iHeard. Just a quick origin story. It's January 2021. COVID vaccines have arrived in St. Louis, and I get a call from Spring Schmidt, who's the acting health director for St. Louis County, who shares with me that her frontline workers across the county are being inundated with claims that they're not quite sure how to respond to about the vaccine. They sound like they're false and they're kind of crazy, but they don't have any way in the moment to respond to those, to counter those. And on that call, we set up what would become iHeard, a way of very routinely monitoring what folks in our community are hearing, and then putting accurate information in the hands of existing organizations that have wide reach, particularly to vulnerable populations. The model I'm going to describe has been, I think, really well received and successful, so much so that our funders at the National Institutes of Health have expanded it. iHeard is now in 5 states, and at the end of this month, we'll announce 4 additional states that are joining. So it's starting to look like what could be, both a collection of local systems, but aggregated up to a national system. I'm just going to talk through what the parts of this iHeard system are and how it works. It starts with a survey. Every Saturday at 2 p.m., we send a mobile phone survey to about 200 St. Louis residents. And across those 5 states, this week, that survey will go to 630 plus community members. And the survey is really simple and really short. It takes less than 3 minutes to complete. And it asks people, in the last 7 days, have you heard, and then fills in the blank with a particular health claim. Could be accurate, could be inaccurate. And if they have heard of it, we want to know where they heard of it, and we want to know the extent to which they believed it. And that's it. That's the survey. We get the answers to that survey within 48 hours. So yesterday at 2 p.m., I got a report that summarized what people were hearing across these 5 states, and prioritizing based upon kind of some algorithms that we've created. What are the greatest opportunities or the biggest threats from an information standpoint in those communities? The response rate across all of these has been 88% or higher for almost 3 years. If you're curious, our panel members look like this, so it's intentionally a very diverse sample of adults. And just to give you a sense of what that survey asks, this is the survey that is going out this week. And so the items that I've flagged in red here are ones that are inaccurate claims. The ones that are green are accurate claims. And then there are some where we're just looking for, sort of opinions and what people know and what they've heard. But you can see, I'm not going to read these, that a wide range of health topics are addressed. And it's not just COVID, as we started out, and it's not just misinformation either. So what do we do with that information once we get it? We do 3 things with it. The first is we put it on these public-facing dashboards. So each community has a dashboard, and there's a national dashboard that'll launch in the next 5 days. And on the dashboard, a couple of things can be accessed. You can see what the responses are. So this is the St. Louis dashboard. And for example, you can see here that this is the week-by-week trend of whether people know about the CDC guidelines being updated around staying home during COVID. And it gradually increased over the first 4 weeks, and at which point about half of people in St. Louis had heard about the change, and now it's in decline. You can also click not just on the data, but to get the accurate responses. So this is a response to a claim that we're tracking that people who got vaccinated for COVID can't donate blood. And here is an accurate information that frontline workers can use should they hear this. And if you click through the tabs, you can see more detailed explanation and evidence around that, including the sources for it. The second thing we do is we put out an alert. And so each Thursday, an alert focusing on the most important health information issue in each of those communities is pushed out in St. Louis to about 150 community organizational partners across sectors, healthcare, public health, education, social services, so that they are aware of what is circulating and they have answers that they can share with their staff. And the third thing that we do is we create digital assets, digital social media assets, and we give these to trusted local messengers and all of those organizations that I just showed you so that they can amplify this information and reach populations and clients that we couldn't possibly reach, from our central source. And of course, we're tracking all of this. The way this works oftentimes is illustrated in this slide. The asset on the left is what we sent out, or the first of several. And on the right is how a local health department took those, rebranded those, and then shared those through their social media accounts, reaching tens of thousands of community members in St. Louis. Just to wrap up here, and I'm really excited to have a discussion that follows and see what questions you might have. But just a couple of high-level points about what we're learning. First of all, it's absolutely feasible to do this. Yes, we have resources, but it can be done. We've been surveying people every week for almost 3 years. They will respond. We can turn around and create assets in a matter of days. Secondly, partners use it. They use the information assets that we provide. It's very well established that in public health practice, but also across community-based organizations, communication capacity is pretty limited. And so it's not likely that most organizations could do this on their own. So having a central source be able to create community-driven, data-driven resources that are locally relevant is useful. Secondly, as we've expanded across the country and in different population subgroups, it's abundantly clear that the health priorities, what people know, what they don't know, what they're not sure about, what they believe, varies a lot. It varies from place to place, and it varies from subgroup to subgroup. And then lastly, and this was a point that I thought Stephanie made really well, having infrastructure in place allows rapid response. And I would just give the example that I would say probably at least twice a month, something happens on a Friday that is really consequential in terms of health information. We are able to put that on the survey that goes out the following day at 2 p.m., have answers 48 hours later, and be responding to it the following week. That's infrastructure that we have not traditionally had in place in public health, and it gives us an opportunity to at least be more competitive in the information marketplace of ideas. Thanks again to our NIH SEAL Alliance partners who support this work, and thanks to everybody for attending today.
Thank you so much, Dr. Kruder. That was wonderful to learn about. The 5 states already using iHeard and the ways community members are being engaged weekly through their mobile phone systems. That so many of us are using those. And I appreciated the shared range of responses and the variability per community. I think that was the fact that you are listening is very present in that and very clear, and that people are using it is terrific to see. Thank you so much, and I can't wait to probe a little bit more about that in a minute. But now let's, and so thank you again. Now let's turn to Dr. Ndaye. I'm looking forward to learning from you.
Okay. Hi, everyone. Thank you. I'm tempted to just what Dr. Friedhoff said and kind of sign off, and some of the things that Dr. Kruder said also are resonating. But I will talk to you about some of these same ideas, and I think it's speaking to the fact that we're able to share the same information or conversion information is really speaking to where the needs are when it comes to public health communication and marketing. So what I'm going to do is really spend some time really reflecting and kind of addressing the idea, talking about the idea of lessons learned, looking back a little bit in the, if we're unpacking public health communication in the post-COVID context, and then looking ahead, finishing by looking ahead and thinking about some of these, what are some of the directions and in terms of some of the work where this work is going. So looking back, I say that with a sense of, with a little bit of reticence, because one of the things that we do learn from this process is the idea that every time there is a public health issue or public health emergency, we draw out lessons, but we seem to not learn those lessons. So we seem to fall on the wayside by the time we reach the next one. So some of these areas or some of these lessons that we're talking about are not new. These are things that we've kind of learned as we went through different public health events and different public health emergency. So they're not new, they're not exhaustive. And I think also it's important to think that all of these things are intertwined. We're talking about misinformation, we're talking about communicating with different populations, those things are intertwined. And there is still some level of unpacking public health communication in this era that still needs to be done, and there still needs to be a lot to be learned. But I will start by talking about communicating effectively across population. And one thing that comes to mind that is important to consider is the fact that understanding culture and context remain critical. This is not new. This is something that we've known for a while, but it is important that we continue to learn ways to speak and create message in ways that resonate with the different contexts and communities that we work with. And as a part of this process, it is important for us to be able to really adopt an ecological lens, even if we're interested in individual behavior, to kind of understand the policies, the communities, the relationships that are impacting this individual behavior. And then to go back to what Dr. Friedhoff and Dr. Kruder was saying, we've approached health communication for a long time as putting information out. And one thing that has become very clear is the need for us to be bidirectional and listening. So it is as much about putting information out that it is about pushing information out, that it is about taking information in. So part of this process, one of the things that we have to learn to do is to listen and to be able to react in relatively quick time, as opposed to just making sure that we put messages out there. So the concept of listening is becoming more and more important. And rethinking health communication and messaging in a bidirectional approach is something that's also important. I think it is also important to learn the lessons related to what do we mean by being truly inclusive in our approach. So one thing that has been already shared by the panelists that's important to consider is the fact that understanding community trust is a process. We're not going to barge into a community when there is an event and get their buy-in or get them to trust them. So this is the process that needs to happen. And as we approach public health communication work, a lot of the work, we really need to be approaching it with the goal of in the planning process of bridging gap between communities and health systems. So to what extent, when we're planning, we're thinking about what needs to be done at the systems perspective, but we also have some engagement in the community before we actually need them to be. So that's how one of the things that's important. And one of the models that I have here is from the Health Communication Capacity Collaborative that talks about to what extent when we think about vision and planning, we have to include this bridge between health system and communities. And what that translates into is being able to co-create messaging with the communities. What does this information ecosystem that some of the panelists have spoken about, what do they look like? And to what extent can we create and co-create messaging using existing ways, existing information sources and information pathways that are existing in the community. And along those lines, it's also important for us to think about expanding cultural knowledge base. One thing that has already been said is the fact that we tend to rely on traditional theoretical approaches that have worked when we are, but that do not necessarily first include this bidirectional approach, but also does not allow us to really dig into what does it mean, what cultural grounding means. So for instance, a few years back, a few colleagues and I were working on exploring what do communication theories look in outside of this Western setting? What if you were to think about what are the contribution of African communication theories? What are the contribution of Asian communication theories? How can we incorporate that in the knowledge base, in the cultural knowledge base as we design messaging? So it is important to really think about that. With that information in mind, I think another important lesson is this: how do we think about addressing misinformation? And this is in line with what my colleagues have already spoken. So I wanted to share this definition because I think it goes back to, there is a point that I would like to highlight. So I'll give you a few seconds to read it. So when we define misinformation in health context based on, again, this is something that Krishna and Thompson did by reviewing the literature, the health communication literature. And they talk about it in terms of the acceptance of false and scientifically inaccurate information. Data is useful despite exposure to scientifically accurate data, in the absence of accurate information, and within historical and contextual legacy. I think this is sometimes this conversation about information management and misinformation is lacking this last part, the part C, which is the historical and contextual legacies. Communities tend to believe false information or misinformation festers in communities because there have been some legacy, some contextual, some historical legacy that is creating, that is a reason why there is mistrust already. So it is important for us to understand that this misinformation doesn't occur in a vacuum. There are some precedents that are facilitating the propagation of information, and it is important for us to consider that and take that into account. So what does it mean in terms of how do we go about doing this? There's been great ways to address this that have been brought up. And I think it's about building health literacy. But beyond building health literacy, it's also important to think about public health literacy. Do people understand what public health does? Do they understand have they seen transparency in the process of sharing information when only the information that we have is not complete? I think I couldn't remember who said that, but this is something that was resonated. Someone, it may have been Dr. Fauci, that talked about how when public health works, it is an inconvenience. So to what extent do people understand assessment of risk, and do we facilitate the understanding of that? Are we able to address uncertainty in the information vacuum? So Dr. Kruder was just talking about the fact that you have consequential information that is happening. To what extent are we able to respond? And it goes back to the example of the I Heard program that Dr. Kruder just presented, where do we have rumor and information refutation strategy? Another example that was done as a response, as a part of response to Ebola, was something similar. It's called They Say was the name of the program, and it involved using text messaging to be able to share rumors that people have heard about Ebola in that case, and then being able to then have accurate messaging being shared through community members, but also through journalists as well. So as a part of this communication planning and health communication planning, it is important for us to incorporate information management, and along those lines, being able to address things like rumor refutation or refutation strategies. With that said, I want to just kind of talk about a few things as we look ahead, and I'm sure we're going to have an opportunity to discuss further in the Q&A. First, the importance of dynamic and social listening in different ways have been presented, and I'm glad that we're able to see some example of how this is done in this panel. But also there is some interesting research in trying to, and this may be related to health literacy, but also using theories like inoculation theory to be able to lead to preemptive refutation. To what extent are people exposed to, or people prepared for the exposure to misinformation, and so that they are able to better respond to it? And are we also using tools and innovative tools to be able to amplify accurate health messaging? So for instance, one of the example, WHO has started using this health alert chat box. It's just one of the example of to what extent are we able to amplify accurate health messaging. So in a study that we did with my colleague, Dr. Evans, using social media to encourage healthcare worker vaccination in Nigeria, one of the things that came up was some of the social influencers who were part of the campaign talking about we cannot fight misinformation, but but one of the things that we can do to our social media is to what extent are we amplifying some of these accurate message. I think we also, if we think about addressing these issues that we have put forth, it's important for us to also build evidence on leveraging digital health. And what that means is understanding, for instance, what is the right mix of digital and interpersonal channels? So to what extent are we thinking about using social media, but also using community media, and what is the right balance of doing and being able to do that? Also, building evidence for innovative tools. So there's been new research, for instance, using AI for segmenting, and also understanding the use, and this goes back to this using social media, the use of influencers and micro-influencers as a way to be able to share information, health information, and then being able to also, again, get some information back through this bi-directional approach. So those are just some thoughts that I wanted to share as a starting point, and then I'm looking forward to discussing further. Thank you.
Thank you so much. It was wonderful to learn from you about reflecting on the lessons learned in communication. Understanding culture remains critical, being bidirectional and listening, being inclusive when we do so, and understanding and building on community trust well ahead of any event. And I love the point about co-creating messaging. It seems to me when people are integrated directly into solving a problem, they're much more likely to trust the solutions that come out of it, incorporating that knowledge base, and also this idea of that you just spoke about, building health literacy and approaches, including the listening with dynamic social listening, but also these notions of debunking, and you mentioned inoculating, or sometimes called pre-bunking, which are also very interesting. So thank you so much, Dr. Ndile. I want to thank all of our speakers for their presentations, which have been fascinating and really built productively on each other. We're now going to move into our moderated discussion with all of our speakers. And as a reminder, I'll be turning to audience questions about 20 minutes or so from now, when we have about 20 minutes to go. And if you would, please do submit your questions in the Q&A box, which is at the bottom of your screen, to make sure that I see them, rather than the chat, because the chat has a lot of other things in it as well. I don't want to miss your great questions. And there are a bunch of them in there now. So I'd like to suggest to the speakers, I'm going to ask at least one question of each of you, and then maybe others can add to the answers as you may see fit. But because Professor Donovan started us off, I'd like to go to her first, if that's all right. Dr. Donovan, I was thinking about the .med idea and the various challenges of social platforms, and something we haven't spoken about too much yet that I would like to start with is what should policy leaders be thinking about or doing when it comes to managing these platforms, which are really shaping our ecosystem? Could you speak to that a little? And then I would welcome any further thoughts from other speakers as well.
Yeah, I think, one of the big challenges right now is looking at the larger information ecosystem and understanding who really benefits from a place where expertise is hard to get, that search engines are optimized for whatever is quote unquote fresh and relevant, rather than knowledge. And so we don't have spaces and places online that are dedicated to what I call talk, timely, accurate local knowledge. That's what people are seeking when they're looking for news, especially when they go online and something piques their interest. You know, we used to talk about this in an international context as having the right to truth, and that it is some information is life or death, but also some cultural information keeps coming back as somehow been invented or embellished. I'm thinking here about Holocaust denial. So on every platform, there's Holocaust denial. But, you know, if you were to Google 5-6 years ago, did the Holocaust happen? You would get whatever is fresh and relevant on the net about the Holocaust. Which is usually a bunch of Holocaust denial, because who's going to wake up every day and just remind the internet that the Holocaust happened? And in some ways, also true around, you have this anti-vaccination movement that really revs up in the early aughts and becomes very, very powerful and persuasive online. But you don't have people coming out every day online and being like, yeah, vaccines are a pretty good idea. I'm really glad I don't have polio. So we're kind of unmatched in terms of advocates for the truth, and then people who are advocates for the kind of, you know, conspiracy or distrust of social institutions. All of this stuff kind of coexists on social media. Whereas, you know, there are places and spaces where we do keep rarefied information, like libraries. They're going to tell you very quickly what's fiction and not fiction, right? That's like right at the top. And so I do think if we brought a librarian's mindset to public health information online, and we did build out these structures that helped people understand, oh, I'm on a .med or a .health website, that means that an institution or an agency has verified the ownership, they've verified the address, they've verified other information that would tell me that I'm on this hospital or this clinic's website. Some of the most persistent health misinformation online has had to do with women's reproductive health. And right now, where women have lost, by and large, the right to their own reproductive health, which is also a right to technology. We do have the right as humans to use technology, especially life-saving technology like abortion services. So it's really important that we understand that the internet has become our default setting for thinking about and learning about social issues. But the internet, and especially social media, has no relationship to truth. It's just information that has been failed to be monetized in other ways. That's what you get from a search engine. That's why you don't get up to the minute or great news, because news is expensive. It's why you don't get scientific papers when you Google for information, because that's also behind paywalls, because it's expensive to generate and distribute that kind of knowledge. Which is to say, I think we need to bring our institutions into the internet, but in a very importantly separate way from just trying to get social media to do better. Because what we've learned about these companies is anything that is fast and cheap, they are going to do it if it makes them money.
Thank you, Dr. Donovan. I was just trying to think of, I mean, I think the .med idea that you suggested might be one way to bring people into, bring institutions into the internet spaces in a separate way, and in perhaps a more thoughtful one than current social platforms allow. I'd like to probe a little bit more on Dr. Friedhoff's suggestion or discussion that she shared with us around how do we go about building infrastructures of trust, and actually all of you spoke about that in one level or another, and specifically, Dr. Friedoff, are there any models you might suggest that where you think people are additionally doing a good job? I liked hearing about iHeard from Dr. Kruder, but are there places where those infrastructures are coming into place that maybe give us some hope?
I shall try. Thank you for the question. So maybe one place to start is that when I was at the White House, I spent a lot of time trying to explain to people the need for this and why it is so important, and the system that Dr. Kreuter has built and is expanding and is funded by the CDC and the National Institutes of Health, I think is a really good example. There are many other examples. One way we can think about this is that through a public health lens, in this pandemic, we have briefly overcome a lot of these barriers by investing a lot of money, but also by working really closely at the local level with community organizations who then came together and connected. So one way we think about this is that at the local level, community organizations or your early warning system. So, and that is true for both information inequities and challenges and general inequities and challenges. So what we saw is by being able to listen and have relationships at the local level, we could say, oh, wait, paid sick leave is a challenge for people to actually get to their vaccination appointment. And you can fill in any of the many examples, but it's an early way for us to understand, okay, where are the barriers and what is going on here? And again, like this point has been stressed, but we can't stress it enough. The disinformation ecosystem immediately and quickly harvests on those barriers and failures, especially also with what Dr. Najari laid out with respect to cultural and historic sentiments and so forth. So in terms of what do we need to build, we see a change in journalism to understand it, sort of a back to the roots of community journalism and being more engaged. Our ethnic newsrooms right now are playing a leadership role on this in building relationships within their communities to become the voices for and communicate around these information needs. Within the journalism world, we can start talking about, we have a misunderstanding that award-winning accountability journalism is somehow more glorious than service journalism, when service journalism is actually where the business model is, and we're seeing examples of that today. At the same time, we need to overcome these barriers of being comfortable of working more closely with community, and also being comfortable working more closely across the ecosystem, because we cannot all do it. Not each newsroom can do it all, so we need these partners. And then when you start thinking about these partnerships, community organizations obviously also have their own channels for online and offline communication, but what they struggle with and ask for help with is like Stephanie, I know the cultural communications piece, but I don't know if there's plastic in clouds or not, right? How am I supposed to know that? So what we can build, so it's another learning that we have from the pandemic, is that we saw experts spring into action in the pandemic. And they have been, most people are not aware, but they have been these informal networks where we were all in the back end on Google Docs. And it's like, oh, wait, this thing just came out, like myocarditis and vaccines. Like, how do we think about this? What is the evidence? So that type of troubleshooting, people volunteered their time to do that. And excuse me, we need to create more formal ways for those who do want to volunteer their expertise to do that, like every once in a while. Also, then it's less disruptive for family and everything else. So this is not about creating another thing from scratch. There's a lot of things already there, but at the local level, they're not connected. So we do trainings with community health workers, for example, who are already information navigators. They help people navigate information all the time. Again, and then this is true for, in our pilot in Florida, we had, a hairdresser. There's a whole important body of work from Dr. Stephen Thomas in Maryland around how barbershops have become engaged and are now CDC certified health promoters. So they can actually get paid through Medicare and Medicaid, right? Be reimbursed for some of this work. So there's a lot of hope in terms of how we can connect the local ecosystem. We just need to put our lens on to say, wait, there's actually an information crisis, and information is a social determinant of health. And we can connect these dots and these people around who does the verification part. So that's where the journalists are great. Journalists are better than most people in both getting to the verification part and then contextualizing the evidence. Then you need to actually put it into communication behavioral sciences best practices. Again, what I talked about with the deficit model just ignores communication science best practices. So we know how to engage people, right? You use all of that, and you do the cultural, like people will say things to us like, no, you can't put in a UN source because nobody here trusts the UN. That information you can only have at the local level, and you need those partnerships in order to know all of these different things. So I hope that wasn't too much at a time, but that's how we think about building these local ecosystems, because a lot of this is already there. We just need to connect the dots.
Thank you so much. And continuing on the theme of local ecosystems, I'd like to ask one follow-up from Dr. Kruder as well. There's a lot of this in the Q&A, which I'm going to come to in a few minutes, everybody. And by the way, thank you for your great questions. Keep bringing them. We'll get to as many as we can. But Dr. Kruder, you talked about the communities and the growth of potential growth of additional members of iHeard, and I think there was a lot of enthusiasm for what you've already accomplished. I wondered what well, for the folks on the Q&A, a lot of folks people have asked how does somebody get to be part of it if they're already a trusted group? Do they contact you? How does that work? But what I'm curious is, have you seen bad actors trying to disrupt what you're doing?
We have not, and hopefully we won't after this widely attended talk. But on the first part of the question, yeah, shoot us an email. We're very open to and excited about exploring different ways in which this can be implemented in communities. And I would just say that we've had a lot of interesting conversations. There's no one model. There's not a particular scale at which it has to happen. And so, so we'd be delighted to talk with you if you're interested. Can I weigh in on the infrastructure of trust question before Stephanie, which I thought was really good. And I was reflecting on how I think we've tried to address that with the iHeard system. And part of it is obviously the community surveys. And we actually refer to that as community listening infrastructure. That's what we call it. And that's not trivial. I mean, every single panel member here talked about the importance of listening as, you know, an expression of trust and interest in what you're hearing. I would add that in addition to asking people about, you know, have they heard specific health claims, every single week we ask people, what else are you hearing? And every week we get 10 to 20% of those panel members who tell us something. That's an incredibly valuable source of information for our environmental scan team. So we have an environmental scan team, obviously, that's, you know, trying to detect what's out there. But hearing from people in the community what they're hearing is immensely valuable. And then the other way that I think trying to build an infrastructure of trust is by thinking about our network of community partners as trusted local messengers and distributors. It doesn't have to come from us. It shouldn't come from us. And I think what we saw during the pandemic was that a lot of public health voices, high-level state and local public health voices, like those voices got old really fast for a lot of people. They were no longer effective. And so having many different organizations and communities with many different interests and stakeholders, I think increases the likelihood that folks you know and trust are sharing this information that can help facilitate community conversation. So super important, I think, to have that.
Thank you, much appreciated. And Dr. Ndai, I'd also like to follow up on, and then I'll go to audience questions in just a couple of minutes, on building health literacy, which was something that that you mentioned as one of a series of things that you mentioned, but I thought it might be a prompt for a question. I would invite you, and then of course the other panelists as well, to talk about who needs to learn what and where in the ecosystem. So there are those of us in communities, there are public health professionals, there are policy leaders, there are journalists. Can we make some recommendations about what sorts of things we should be aware of so that we may be more public health literate?
I would say that we all need to learn. Maybe one of the things is the level of learning is something that would be different when it comes to what we want policymakers to learn to the community. But I think even if we're thinking about it in schools, I think this is something that may be starting in terms of the conversation. And to me, it wasn't just about information and health literacy, it was also about public health literacy. Do people understand what public health is about? Do they understand what it does and how it's not an exact science? And as we're facing with any major health issues, we don't have all of the answers. And that's okay. And how do we present that information? So I do think that there is learning that to be health literacy learning at all levels. And part of what we have to do is, to an extent, we have to be better at translating messaging for different audiences and being able to share health literacy and being able to create health literacy curriculum that speak to these different communities and different audiences that we work with.
Anyone like to add to that? Maybe you're looking, Stephanie, like you'd like to.
Yeah, I'll just add we need to embrace the micro learning that happens on social media all the time. And we talk a lot and see, and for all the right reasons, about all the bad content that is out there. But there's a tremendous amount of good content also out there, especially told from personal perspectives. After the fire in Haiti, I remember coming down in our household, the New York Times is in print on the table because we're old. My 18-year-old reads the story about how climate change led to the fire, and she's like, oh my God, don't they know anything about, what went in here and how communities have been repressed? And she had an amazing understanding of the historic and socio-cultural drivers of what had led to this moment that went way past what was in the New York Times story. And we had multiple conversations about it after, but I think paying attention to, it's not just a long story that teaches people things. And think about how we all as human beings learn. We learn in bits and pieces. And embracing the micro learning that can be out there, I think, is a key piece that we keep missing. And that is why, our youth spends time on TikTok and learns a lot in these types of places. But let's also remember, our government is not on TikTok because Congress banned that the CDC and other people who actually have important and useful information cannot be on these platforms. So you asked earlier about policy solutions. That's a really important question. And what we should not do is further stymie how our experts can engage in these spaces.
Can I add quickly, when we're talking about also going back to trust and infrastructure, to me, it's also about making sure that we have people who are part of these communities, whether as to have them a seat at the table, but also really listen to them. So they're not the interns who are sharing some information, but they definitely have a seat at the table and they're part of the decision-making process.
Thank you. Well, we're at that time where we're going to turn to questions from the audience. There are a lot of them. There are great questions. I'm going to try to do justice to as many as we can. One of them I think might be a quick follow-up on the point about engaging communities, but it's specific to the authorities on health, such as the CDC, the FDA, and so on. And the question was, how can authorities like that start to win over the trust of people who don't believe in their work? They're not ingrained in the communities. Are there some approaches they can take? Would anybody care to take a whack at that one?
This isn't a direct response to that, but a few weeks back, a month ago, when CDC did announce its updated guidelines around staying at home when you're sick with COVID, we actually added a little mini poll on iHeard, and we asked people if they had heard about this change, and then we explained the change, and we asked whether it made them trust CDC more or less, or it didn't change how they trusted CDC. Overwhelmingly, it didn't change how people trusted CDC. But for those who did change, and it was about 20% of people, there were some interesting differences. So it made men trust CDC more. It made women who said they changed, it was more likely to make them say they trusted CDC less. So, I mean, that suggested to me that part of it is like, where did you begin? Like what were your priors about this policy and this organization? But I think what that illustrates is not so much how can they regain trust, but that trust is movable, at least in some subgroup of the population.
Dr. Kruder, I'd like to stick with you for a minute. This is sort of a follow-on question to the point you were just making, and a couple of our audience members have asked it. When you're sharing with people false claims through, iHeard, how do you mitigate the risks of maybe inadvertently legitimizing something or people getting confused? And I know you're also addressing, but maybe to maybe to repeat or expand on that.
It was a super big concern for us. And so what happens is when you answer a question, have you heard X in the last 7 days? Regardless of your response, the next thing that appears on the screen is short, accurate information, like what we know right now about this. So we would never make one of those claims without providing the accurate information. Now, we've also analyzed this pretty carefully to see whether those little follow-up, accurate information items move people from 1 week to the next. And the short answer is that they don't move them very much. Not surprisingly, the people who are most likely to change from week to week are those who were uncertain to begin with. They were sort of on the fence. They didn't, definitely believe something was true or definitely believe it was false. They just didn't know. But those people move in about equal proportion towards inaccurate or towards accurate understanding of claims. So it doesn't look like it's doing any harm, but nor does it look like it's having some overwhelming beneficial effect on the panel members. I would just close with, this was another question in the chat. It's a panel, so we're reaching out to the same people each week. It's entirely possible that some of them don't even stop to read the little accurate statements anymore. They sort of get the hang of it and they know. So it's possible that may not be a meaningful exposure one way or the other.
I also, there's another good question there are many good questions. Another good one I'd like to toss out to our wonderful panelists today, which is, how can we as public health leaders and practitioners help our citizens be comfortable with uncertainty and change as scientific evidence evolves? In other words, for them to think of it as a feature, not a bug, that recommendations may change. Any thoughts on that?
Yeah, acknowledge it for sure. I mean, acknowledge uncertainty. Here's what we know, here's what we don't know. I don't think we were particularly good at that during the pandemic, and we should be transparent about those things.
Yeah, I actually, in preparation for this, went back to look up the literature and see what our latest understanding is of all of this in general. And because, like, from my experiences throughout the pandemic, I've often felt that the overinsurance by authorities was really painful and has a lot of negative impact. And at the same time, people aren't stupid and we all have uncertainties in our lives. So this like overblown fear of people can't handle uncertainty, I think is actually not necessarily what some of the questions are about. Now, people don't like change, right? And uncertainty in general creates an adverse reaction, but not in all cases. So we can, do a better job understanding that. But more importantly, communicating the I don't knows is a key important factor, and then communicating with authenticity. So to your earlier question, I think what authorities need to learn is to overcome the stale voice and the official speak and communicate with authenticity. And there's two examples of folks who do that really well right now. One is Cody Kinsley, the Secretary of Health in North Carolina, just a fantastic, if you just want to follow his LinkedIn tweet, it's a masterclass for how to engage with the public. And the other one is Dimitri Daskalakis, who's the head of the National Center for Influenza and Respiratory Disease at the CDC, who was the monkeypox lead. But those are just two examples for folks who can communicate and engage with communities in ways that we rarely see. And that should be, the feature, not the exception.
Thank you. Also acknowledging what we don't know. I hope this doesn't make folks uncomfortable, but a good question here. We've been talking a lot about existing platforms and some new efforts like I heard, but how do you anticipate technologies that are coming along, like this fairly recent still emergence of generative AI, which we've touched on already in this discussion? How might they shape or reshape the landscape of public health, communication, and misinformation, and what should we be doing to prepare to deal with that? Joan, I wonder if this
I would say that avoiding it is not an option anymore. So that's one thing, and to just kind of say we don't want to engage in anything that has to do with AI is not an option either. So I think part of it is learning. For us and who are not very familiar and in the way how AI works, for us learning a little bit more and then understanding how this can be used. So for instance, one of the examples that I had of studies in looking ahead of really talked about how they can be very useful in segmenting and being able to tailor messaging to different based on needs and based off questions that people have. So I think there's still a lot of learning to be done, but I think one thing that's clear is it cannot be ignored.
There are many. Oh, I'm sorry. Please go ahead, Dr. Pudov. I'd like to.
I want to hear from Joan also, and I don't want to take up too much space, but I think we need to understand, and Joan touched on that a little bit. Things are going to change dramatically in the next 5 years. We're thinking about Google. Google is the past. Alexa, right? Alexa says the 2024 election isn't happening. How does that even happen? And personal robots, information that comes from the fridge, right? What AI is doing, it is powering together with, again, the development of devices. It is going to change where we get our information. And again, another way, we're focused on the phone right now and social media. This will go into all our living spaces in a fundamental way. And we need to invest in the sciences to understand what that actually means in terms of, right, we have these behavior change models in communication. Who gets to decide what information goes where? There's so many questions here that are really urgent for us to think about and to address. And the key point is communities and people are not currently part of the planning for all of this, the design. So Joan called out the design. Design is so important. The designs are being made by businesses. They're not being made by authorities or government, and they're not being made by the people. And that's a real challenge that we need to think about.
Yeah, I'm as we head, diving headfirst into the shallow pond of AI, currently the hype that we are going through is capturing the attention of a lot of decision makers at institutions. They're wondering, you know, how do I get more labor out of less people? The same things that sold, you know, car manufacturers on, you know, autonomous workplaces in the 60s is the same thing that's the same rhetoric driving AI and this question of, you know, you don't even need a communications department if you have AI. You know, these technologies are always going to come to us in these moments where they want to magically make it seem like they can fix all of the problems of media manipulation, misinformation, you know, even in terms of child's health and well-being. They're talking about AI as personalized tutors. But again, AI has no relationship to the truth. AI, as it's designed, is pulling data from Reddit and Wikipedia, and then everything else that's been posted on the internet. What's interesting is information that is behind paywalls then are not in AI, or information that is in news, information that's from some of our more reputable academic publishing houses like MIT Press, that is not in these models. I think also the other thing is that we have to worry about in this day and age is the way in which we talk about technology, especially as it pertains to the question of community. YouTube was content to tell us that the entire, you know, 2 billion users of YouTube are the community. That's not how community works. We also know that younger people have lived through this moment of their lives where they should have been very social, living through it in a very isolated way and reaching out through digitally mediated technologies. And we're not going back from that. So 5-year-olds that got iPads during the pandemic are staying online and they're not leaving. So what does it all mean? Well, it means we need really strict policy around data collection. We also need new laws around biometric information privacy, which currently I think only Illinois has. Any kind of deep fake that's made out of your face or your voice, that information is yours and yours alone. It's the same thing as copying genetic information or a fingerprint, which is to say that I think there are ways in which we've allowed technology companies to get away with so many things because we assume we live in a world without policy, but rather I challenge us all to think about technology as the policy until we get laws that change or protect consumers. Which is all to say that like public health communication is a rarefied challenge, because what we care about in terms of public health communication is that people are making informed and consensual decisions about the medicines that they take in. We are better off as a society if we have critical thinkers, especially people that are willing to question, you know, why would I trust big pharma? Why would I trust this? You know, why would I trust that? And unfortunately, if you start by doing the research online, you're likely to run into misinformation more often than you are to run into facts because of the design of this system. And so, you know, I think as we move forward as a field in terms of public health, that the best way to go forward is to think about, well, what are the infrastructures that need to be built that allow us to pull together different kinds of information and remain up to date, pun intended, for all you nerds out there that love a good medical database joke. You know, but I think that kind of information does need to be available to patients as they're thinking about, you know, navigating complex health territories. I also think another thing needs to happen transparently, especially in the US, which is these insurance companies, they will fight not to pay for anything. One of the big problems with the pandemic is that very few poor people knew the vaccine was free, right? If they had known the vaccine wasn't going to cost them any money and that by getting it, they weren't going to get charged, some doctors were charging a facility fee. So you go in and then you have to pay the $150 or whatever just to get the shot, not knowing that they could just go to the local pharmacy to get the shot. I do think that when people realize, the extent to which government or others have really foregone some kinds of profits or some kinds of even some kinds of clinical trials, it's because of the expediency of the demand or the expediency of the crisis. So there are points where it's important for science to be slow and laborious. And then there are points like, this pandemic or the AIDS crisis where we need to be more responsive to people.
Thank you. I think I know we're almost out of time, but I'd like to try to just squeeze in one. It's probably a big and unfair of me a question, but it's an election year. We have two political parties in the U.S. at least that are a little different how they look at scientific research and information. Any advice for how to approach the next month's conversation? Any last words on that score?
Well, I'm worried about 2024. What we know about these platform companies is they've laid off immense amount of research staff as well as trust and safety staff. They are no longer, at least publicly, committed to news sharing, especially Meta, that owns Facebook, banned the news in Canada after there was some policy put in place where news that were news that was being distributed over platforms needed to be, these platform companies had to pay into a public fund for journalism. Threads has made a commitment that they are going to serve less political information, but they're not banning political ads. So that's a very strange setup there, which means political information is going to come at you at a premium, which is to say, as best you can, watch the local news. Generally, they do a pretty good job of cutting through the BS, and then be prepared to argue for the truth. I mean, now more than ever, truth needs an advocate. And I think that one of the things we can do is utilize our own social media profiles as a way to be a newsstand for one another and to focus on curating our own content in a way that will help others in our families and networks get the best of us in terms of the way that we share information.
Thanks so much, Joan. I'm sorry, we're just about out of time, but I thought that was a nice note to end on, both concern and hope, and that some of it at least is in our hands. I'd like to pass it back to Dean Galea with my thanks.
Well, first of all, thank you, Dean DiCristina. Thank you to all four of our panelists. What a terrific conversation. It's very hard to summarize a conversation like this, but I will perhaps end on quoting Dr. Donovan, that truth needs an advocate. I thought that was actually quite a lovely turn of phrase. These conversations are meant to be conversations, and I think this one excelled at that, both in terms of seeing the number of questions from the audience, but also the conversation the audience was having amongst itself and with some of the panelists. And I think that reflects how much of interest this topic is to all of us today, and how much we all recognize that there really can be no effort to thinking about how to best promote the health of the public going forward without wrapping our brain around how we communicate. And if there's one field in public health that is really emerging as a field that's fluid right now, it's health communication. So really, to have these panelists who are at the forefront of thinking about this joining us today is a real privilege. I want to say thank you again to the panelists. Thank you to our hosts, thank you to translators, and to everybody in the audience. Everybody, have a wonderful afternoon, evening, or morning, wherever you are. Take good care.